So currently the NCCN guidelines recommend either sorafenib or lenvatinib for the treatment of patients with RAI refractory differentiated thyroid cancer. And there's actually a preference for using lenvatinib if all other comorbidities and everything else is equal. And the basis for that, I believe, on the opinion of the experts who wrote the NCCN guidelines, is that there is a higher response rate with lenvatinib over sorafenib. And I think that together with the fact that there's an overall survival advantage is why lenvatinib is currently preferred in the first line setting. Comorbidities will play into whether or not you will give sorafenib first versus lenvatinib. And if patients have extremely high blood pressure, many times lenvatinib is not the preferred choice, and sorafenib, which can cause higher blood pressure but not to the same extent, would be preferred in that case. There are also some patients who might have invasive disease into the neck that I might want to control a little bit more gradually instead of having these very, very rapid responses, and I have done that in the past. Interestingly, in both cases, when I've had to use sorafenib first or lenvatinib because of a toxicity or a high-risk setting, many times I eventually have to give the other agent anyway. And in the case of lenvatinib, I can start with a lower dose if I'm concerned about either blood pressure or invasive disease. Age is another interesting marker, because we know in patients who are over 65, they'll have improved overall survival. So I think this is again why, in general, lenvatinib is chosen, and half of the patients will be over 65, so that's a common reason for lenvatinib to be a preferred agent. The data showing that overall survival was improved is important because this was practice changing, and that it was the first time overall survival was shown to be improved in patients who had who are being treated with a kinase inhibitor in this setting.